As PSCs, we are the delivery arm for the improvement element of the patient safety strategy. We are directly accountable and commissioned by the National Patient Safety Team. There are 15 PSCs across the country, and we're responsible for the delivery of the National Patient Safety Improvement Programmes. Next slide, please. So on this slide, you can see a driver diagram that shows the National Patient Safety Improvement Programmes. And the one highlighted in orange is the System Safety Programme, of which the scale-up and adoption of PSIRF is an integral part. Next slide, please. So once again, we'd like to welcome you to this webinar and thank you for joining us. At the West Midlands PSC, we wanted to create a series of webinars to support teams and organisations to prepare for the implementation of PSIRF. And we wanted to have an approach that has a positive safety culture at its very heart. This webinar is not here to provide all the answers, but what we are here to do is to provoke your thinking and provide opportunities for shared learning and insights. Many of you will be working in fast-paced and complex environments. And we'd like you to take this opportunity to pause and consider what replacing the serious incident framework with PSIRF means to you. My challenge to you is, what are your aspirations for PSIRF? What does good look like for you? And what can your influence upon that vision be? Today we want to generate discussions and share ideas, so please do share your thoughts in the chat and during our Q&A session later on. Today's webinar will explore human factors and the SEEPS framework, which allows us to focus on the people in a process. This framework facilitates a systems approach in which we're trying to understand the important interactions that either support or challenge the good outcomes and help us target those areas for improvement. It enables us to get into the workspace and understand work as done as opposed to work as imagined or prescribed. This takes us away from a focus of the individual being blamed and moves towards a just culture in which the people have the psychological safety to speak openly about incidents. We want a positive safety culture that enables compassionate and meaningful engagement for all who are affected by patient safety incidents. We are going to explore in this session why it is critical that we use human factors to get that meaningful and compassionate engagement. On that note, I'm thrilled to announce our keynote speakers for today's webinar. Firstly, I'd like to introduce Fran Ives, who is a chartered ergonomist and human factors specialist that works with us here at the West Midlands Academic Health Science Network. Fran has developed a human factors service which provides leadership to West Midlands AHSN supported programmes and health and social organisations within the region. We are also very happy to be joined by Steve Tipper, who is a chartered ergonomist and human factors specialist working in the patient safety team at the University Hospitals Coventry and Warwickshire. As part of his current role, Steve undertakes safety investigations as well as training other staff in investigation skills. So thank you for listening, and over to you, Fran.
Great, thanks very much, Dale. Can we skip straight on to the next slide, please, Claudia? Great. So what I want to do today is to really explore human factors. I'm always really aware that when I talk about human factors and when I deliver sessions on human factors, I never make the assumption that people are comfortable with the term. So we may have some people on the call today who are really well versed in the scientific discipline. There will likely be some who have an idea what human factors is, and there may be others who are yet to discover this fascinating science. So wherever you are in terms of your understanding, let's begin at the beginning. So I'm going to provide an introduction to human factors during the session today, and then I'm going to move on to talk about the SEEPS framework before passing over to Steve to continue the session. Next slide, please, Claudia. So the term human factors means different things to different people, and that's certainly what I found throughout my career. So over the course of my career, I've been known as an ergonomics engineer, a human factors engineer, an ergonomics advisor, and now a human factors specialist. Ergonomics and human factors, it's a scientific discipline concerned with the understanding of interactions amongst humans and other elements of a system, such as equipment, environments, organisation and task. Now, the term ergonomics was used for professional practice in the UK from the 1950s, and the term human factors was used in America a few years later. But over the years, these two terms have been harmonised in many English-speaking countries. So lots of our societies, our institutes and our associations use both terms, human factors and ergonomics. So in the UK, we have the Chartered Institute of Ergonomics and Human Factors who use the two terms interchangeably. So that's what I'm going to do today. In healthcare, the term human factors is more commonly used than ergonomics, but we may use both of them today in the session. Next slide, please, Claudia. So as with all sorts of different sciences, disciplines, etc., there are various different definitions around, and many of them are very, very wordy. But I like this one from the International Ergonomics Association, and the reason I'm sharing it with you is because it's fairly nice and succinct. So the definition says that ergonomics and human factors is a scientific discipline concerned with the understanding of interactions amongst humans and other elements of a system. So human factors is a profession that applies theory, principles, data and methods to design in order to optimize human well-being and overall system performance. Human factors specialists contribute to the design and evaluation of tasks, jobs, products, environments and systems in order to make them compatible with the needs, the abilities, but also the limitations of people. So in human factors, when we're talking about systems, we're talking about people, we're talking about tasks, equipment, environments, and organisations, and the interactions between all of those elements. Next slide, please. So straight away, I'm showing you the SEEPS model, which many of you may be familiar with, and we will talk more about this in the session today. However, the reason I'm showing you this now is because it's a diagram that I use quite a lot when I'm talking about human factors, because I think it really nicely describes the main areas and it gives us a really good framework to use. Next slide, please. So what I want to do first of all is to focus on the work system section at the left-hand side. So at the centre of human factors are people, and it's really important that we understand people, their anatomy, their physiology, their anthropometry, and we consider and understand how they might interact with other elements of the system. Those system elements being tools and technology, organisation, internal and external environments, along with the tasks that they're completing. So let's delve into some of those system elements a little bit more. So next slide, please, Claudia. So first of all, let's think about our people. So people are right at the centre of what we do. And it's really important that we understand people. We understand their knowledge levels. We understand their competence, the sorts of skills that we have and the mix we have on any one shift. What's the level of education like? What education are we providing them as an organisation? What are their psychological characteristics? And what are their physical characteristics? So thinking about the anthropometry, the biomechanics, how people move, different statures, etc. When we're thinking about tools and technology, if we move on to the next slide, please, Claudia. We're really thinking about the sorts of equipment that people are using. We use a huge range of equipment within our hospitals, and some of that's really, really complex, and some of it's extremely basic. We need to understand how usable our pieces of equipment are. How familiar are people with them? Is this a piece of equipment that they're using day in, day out, and they could use it with their eyes closed? Or is this something that's only used every so often? And actually, people feel a little bit anxious about pressing the right button or plugging it in the right way. Thinking about accessibility, where are pieces of equipment located? Are they easy for people to get when they need them? What's the functionality like? Do they do what we expect them to do? Do they do what we need them to do? If it's a piece of equipment that needs to travel around the hospital, is it designed to do that? Is it portable? Does it have the right wheels to do that? How heavy is it? Is it going to fit in our lifts? There's nothing worse than setting out on a journey and realizing you can't get to where you want to go because the equipment won't fit, or it's too heavy, or you can't go down your route. Is your equipment working properly? Is it maintained? Or is it one of those pieces of equipment that you think, I'm not going to use that. It's always broken. It never works as I expect it to. What's the automation levels of the equipment? And inevitably in healthcare organisations, we're going to have different models around that may trip people up. If you're on one ward and used to a particular model piece of equipment, then you go into another area and there's perhaps a newer or an older model that works in a slightly different way. What impact is that going to have for the user? Next slide, please. Let's think about the sorts of tasks that people are doing. We do numerous different tasks throughout the day, and some of them will be things that we do really frequently, and some of them will be things that we maybe do once a week, once a month. Some of them will be really simple tasks, and others may be really complex. Likely, we'll have a real mixture of the two. So there may be some tasks that we're doing that are very familiar to us, but there might be some tasks that are less familiar. Think about the variety of tasks that people do. Some people have a huge variety throughout the day, whereas others have very repetitive jobs where they only do a very small amount of tasks. What's the content of those tasks in terms of how much do they challenge people? How much are they utilising the skills of our staff? And what does that mean for our job demands? So what's the workload of our staff? What are the time constraints? Are they constantly working under time pressures? And what's the cognitive load like for them? And then if we move a little bit broader from thinking about specific tasks, try to understand how those tasks fit into our larger work processes. Next slide, please. So let's think about our internal working environments. So in a hospital, we have a huge range of different working environments, and we may well be working in lots of different ones. Let's think about that internal environment and what it's like. Lighting levels is really subjective, and we might want different lighting levels for different areas. So the level of lighting we would want in a corridor, for example, is going to be less than what we would want in an operating theatre. Think about noise levels. Are they appropriate? Are they going to be too high for people to actually hear what others are saying, or for them to hear alarms or anything else that they need to keep an ear out for? What's the temperature, humidity like? Any vibrations? What's the physical workstation layout? Is it conducive to the work that's going to be carried out? Is there enough space? Is it clean? And how's it organised? So when we actually delve into each of those system factors, there's an awful lot for us to think about. Some of them we may be really, really comfortable with, and other areas we may think, well, actually, I'd not really thought about that before. We move on to the next slide, please. So I often say to people that one of the most valuable things to have in your human factors toolbox is a curious mind. Being interested in people and how they operate within their work systems, and using that curious mind to ask questions, to observe and to understand. Now, when I first moved into healthcare nearly 20 years ago, I came from the nuclear industry where I worked as a human factors engineer. So my world up until that point had all been all about pumps and turbines and reactors and control rooms, and I knew next to nothing about healthcare. Now, I quickly realised that actually, rather than this being a disadvantage, it put me in a really great position because it gave me the ability to ask what others might think are really dumb or really obvious questions. Sometimes these are the most important questions to ask. So things like, can you tell me a little bit more about what you're doing? That's a really interesting piece of equipment. How do you use it? Is this a common procedure? Being a human factor specialist in healthcare means that we can go anywhere and everywhere. So Unlike, say, a renal nurse, a microbiologist, or a respiratory physio, we don't have clinical specialities, meaning we'll never be an expert in a particular area. And those curious questions are always going to be asked. So going into a place without any preconceived ideas about how something works or how it should be performed is actually a real advantage when it comes to understanding work. Because when we're trying to understand human work, we need to look in different places for our information in order to build up a true picture of what's really going on. Inevitably, we will draw on our work as imagined. So individuals may imagine what other people are doing. So work as imagined can take place between and within organisations or from people outside an organisation. For example, you as individuals may imagine what your nursing colleagues do. Your operation staff will also imagine what nursing colleagues do. Their counterparts in other trusts will also imagine what your colleagues do and imagine how their work might be organised. And outside of the organisation, we'll have the general public or ICSs who will also imagine what your colleagues' work involves. Now, within these imaginations, our mental models, there'll be some elements that are correct and there will be some elements that are incorrect. We really like to simplify much of what others do, and we might not have a complete picture of what it is they're doing, or indeed we might get complete chunks absolutely wrong. So often we'll base our work as imagined on maybe past experience of doing that job. We may have had sight of the procedures that are being used, or we may have had a conversation with somebody some time ago who's doing the job. Whilst these give us some information, it can also introduce some problems. You know, what if we did that job, but it was actually 5 years ago? Our experience can really quickly become outdated, particularly as patient numbers increase, equipment's upgraded, or staff levels change. So when we use work as imagine to try and understand work without involving those people who are actually doing the work, we can run into problems because we won't have the right picture. When we think about work and put another piece of the puzzle together, we will also draw upon work as prescribed. So this is things like what's detailed in procedures, in checklists, job descriptions, laws, regulations. Now, every one of us today can imagine how a single job is carried out, and we'll all have slightly different ideas, and there could be an infinite number of variations of work as imagined. But each task or role will have a finite set of work as prescribed. But think about who actually writes these laws, these procedures, etc. Are they the people on the ground? Sometimes they're written by people who are removed from the task. They might be slightly removed, internal managers, or there might be people who are greatly removed, such as regulators. Also possible that these documents have been written by people who've never actually done the task before. Now, work as prescribed is assumed to be the safest and most correct way of carrying out the task. You know, they may be used to inform risk assessments and standardise work, but it's not always the best way because it's impossible to prescribe human work. There may be many, many different ways in which work can be carried out, despite there being one single way prescribed. We will often also look at work as disclosed, which is how we talk and how we write about work. So when describing what we do, we may write or say things in slightly different ways depending on who we are talking or writing to. So think about if you were asked to describe your job, you know, would what you said or wrote changed if you were asked to deliver the information to an audience of school children or a patient, a nursing team, an ops manager, chief executive, media, etc. The language you use may change, as might the purpose of the message. You might give an answer that was deliberately challenging or controversial. And then lastly, thinking about work as done. So this is the messy reality. This is actually what happens on the ground, what you might see if you're actually going to observe something. It's real life activity. It can be messy. It can have shifting goals, variable demands. It might have insufficient resources. And it's impossible to truly, really describe those work has done, because it changes frequently due to either small or large adjustments, trade-offs, compromises, and staff make adaptations. They may not necessarily realize that they're doing it or consciously do it, but adaptations are often necessary to carry out work and meet a demand. Sometimes they can work really well, but sometimes they can put staff and patients at risk. So there'll be overlaps between all of these elements of work. And, sometimes we need to just take a step back, put all of the pieces of the jigsaw together and really understand what's going on, looking at all those different elements and examining the different types of work. Next slide, please. So let's turn our attention to SEEPs. So SEEP stands for Systems Engineering Initiative for Patient Safety, and it was developed originally in America in 2006. This was followed up by SEEPs 2, and then SEEPs 3 in 2020, and SEEPs 101 in 2021. The most well-known model is what we're going to talk about today, which is SEEPs 2. So the first SEEPs framework was really developed to provide a framework for understanding structures, processes and outcomes in healthcare, and also their relationships as well. The writing team recognised that most errors and inefficiencies in patient care arose not from solitary actions of individuals, but from conflicting, incomplete or suboptimal systems of which they were a part of and within which they interacted. So SEEPs can help us to understand how different system elements interact, and then how these elements contribute to the work that staff and patients undertake. And you can then look at how the system interactions and work contribute to both successful and unsuccessful outcomes for the staff, for patients, and for the organisation. So one of the strengths of SEEPs is that it focuses on system design and the impact of those processes and outcomes. So it takes a really broad view of processes, and it really enables us to understand each of those different elements. But let's move on to the next slide, where we look at the process section. So this process section in the middle considers different types of work activities. Now, these could be paid or unpaid. They might be core or peripheral to care, but all result in accomplishing some kind of goal or outcome. So SEEPs recognises that a number of different types of work activities are carried out. Now, some of those activities are carried out by professional staff, who could be people like nurses, doctors, pharmacists, OTs, or A&C staff. So these people don't all have to be providing clinical work, but they're still engaged in work activities that are relevant to the area that you're looking at. Patient work is a really general term used to capture patients, but also any family or caregivers. There's a growing recognition that many patients engage in health-related activities, and they aren't simply passive recipients of medical care. And in fact, often patient engagement in medical-related activities is really vital. So think, for example, about patients actively undertaking cardiac rehab, taking medication, completing physio exercises, booking appointments, or preparing for a procedure. So it's therefore really important that we recognise patient work and that we factor this into our work systems in order for it to be appropriately supported. And then we have collaborative work, which is where patients and professionals engage in work together. So an example of this would be during an outpatient visit. Both sides are providing and processing information. Next slide, please. So on the right-hand side of the SEEPs diagram, we can consider the work outcomes for patients, professionals and organisations. So outcomes here are designed as states or conditions that result from the work process. Some of these outcomes may be immediate, whilst others may only emerge over a period of time. And of course, not all outcomes are desirable, so we must consider that our outcomes may be both desirable and undesirable. So what kind of outcomes may be important and relevant to each group? Well, for patients, outcomes could be quality of care, how satisfied they were with the interaction they had with the staff and the procedure or the appointment they had. For professionals, we might be looking at things like job satisfaction, stress, fatigue, positive team working, or work-life balance. And organisations may be looking at outcomes relating to staffing levels, waiting list times, compliance with regulations or targets. Next slide, please. So I've mentioned the SEEPS 101 paper and I've referenced it at the end. And this is a paper, if you haven't already explored, is worth having a look at because it gives you some tools and templates to help you use SEEPS in everyday work. Now, I've pulled out one such tool called a PET scan and I've replicated it here on the slide. So this tool enables you to look at each of the SEEPS elements and consider what the facilitators and barriers are for each. So the PET scan tool helps you to consider the full breadth of the work system and to indicate the aspects of each component or interaction that either hinder or support people in their work system. For example, their ability to carry out a task or interact with each other within the system. So this tool can be really useful when project planning, when designing interventions, or maybe you're evaluating interventions. So there'll likely be a number of people on the call today who've heard about SEEPS, read about SEEPS, maybe listened to people talking about SEEPS, but may still think, how the heck do I get started? It may feel really alien and it may be really hard to know where to start. So I'm showing you the PET scan because I'm hoping it's a tool that will help structure your thinking or get you started. It's not going to do everything for you, but it can just be really useful to have that starting point to understand who your people are, what your environments are and what needs to be considered, what tools are being used and the tasks being undertaken. And from there, you can then think about and identify the facilitators and barriers for each. So next slide, please. So we're now going to have a go at doing a PET scan. So for this, you'll be moving to breakout rooms. And within those rooms, I want you to have a think about your own organisations and the implementation of PSIRF within them. So all I want you to do is grab a pen and paper and in the rooms, jot down some thoughts around who your people are, your environment, your tools and tasks. And once you've done that, go further to think about one or two facilitators and barriers for each. Now, there's going to be some people who are very, very much at the beginning of the implementation journey. And in the exercise, you may need to think ahead about what you think the facilitators and barriers might be. There may also be people who are further along down their implementation and they can draw on their own experience. So you'll have a facilitator in each room with you. So please use this time for discussion to share your thoughts and ideas. And you will be brought back into the main room automatically where your facilitator will give a golden nugget from each room. So what I'm going to do is ask for us all to go into our breakout rooms and we can get going and have a think about our PET scans. Thanks everyone for participating in the breakout rooms. So I'm going to go to each of the facilitators quickly to give a golden nugget, but I'm just going to share one with you from my group. One of the things that one participant talks about was engaging with primary care. And when you've got 79 practices to engage with, they're all going to work in a slightly different way. So what that means is you're going to get some people who are doing absolutely brilliantly, and hopefully we can share that learning because inevitably you're going to have some practices that are struggling slightly or finding it more of a challenge. So in those situations, it's going to be really important that we share that good practice, but a huge task as well. Dan, can I come to you for a nugget?
Yeah, of course. So I think in our group there was a real I mean, to get through the whole PET was going to be difficult, but I think one of the golden nuggets was around culture, and that actually that influencing factor of successful implementation of PSIRF was around culture, and that's imperative about how do we start thinking and feeding that back into all forms, whether that's at board level or frontline, so that everyone's really clear about their role and responsibility in PSIRF.
Yeah.
So to drip feed that culture a little bit differently because it is a change.
Brilliant. Thanks, Dan. Steve, can I ask you for a golden nugget, please?
Yeah, we didn't get all the way down, but
That's fine.
certainly looking at people, I think one of the things that was raised as a potential facilitator or barrier is the, you know, what you could call high leverage people, the people who, if you get them on side, it is going to make it inestimably easier. And if you don't get them on side, it's going to be an absolute nightmare. So it's about identifying the people who are going to have a lot of clout one way or the other about whether this works, and targeting them early.
We had exactly the same discussion, Steve. So yeah, that's common. And then lastly, Vicky.
Hi, Fran. So we had some really good discussion in our group, and we talked about thinking about this through that lens of work as done as well, and very much about when we're looking at these as possible incidents, to think about doing the, you know, walking the walk, to go and having discussions with those people involved within their work environment. So you're looking at the people involved and you're looking at the environment in which they work, just that giving that greater understanding rather than work as imagined, but to work as done. So it gives you those really valuable insights into what's going on.
Brilliant. Thank you for that feedback. Sounds like you've had some good discussions there. So we'll just move on to my last slide, please. Oh, is there one before that, Claudia? No, not to worry. So really, you might be thinking, how can I apply SEEPs to my work, and why should I? Hopefully you can see from the slides that SEEPs can really help you to understand how care is being delivered in a systems perspective. It can be used to horizon scan, it can be used to problem solve, it can be used to inform system design. So it's a really versatile framework to use. I'm now going to pass over to Steve to talk a little bit deeper about SEEPs. So thanks, Steve.
Thank you. So I'm going to talk about a couple of different aspects of SEEP here. One of them is around the work system itself and what actually makes a work system, and also then about the interactions bit. So, you know, so far, you know, if you're looking at doing a PET scan or something, you might be thinking, well, how is this different from the contributory factors in the contributory factors framework? You know, we're just picking out these things we think are important. But using SEEPs, it's not necessarily just about which ones individually appear to be the most important. It's which ones might have the biggest, broader impact or influence across the system, and how sometimes ones that maybe seem quite small in isolation can actually have a very big impact. And it's trying to identify those high leverage points that you can press to actually get a broader impact across what you're trying to do. So next slide, please. So hopefully you're becoming familiar with SEEPs. You're probably not seeing it in the insides of your eyelids when you close your eyes, like myself and Fran are by now, but you will become, I'm sure, intimately familiar with it as we go through this. And the SEEPs model has got these 3 steps. You've got a work system that leads to a process that leads to an outcome. But you can see, actually, if you look at the arrows at the bottom, they're actually going the other way. And we're starting with our outcomes, understanding the processes involved that lead us to those outcomes, and then exploring the work system that's required in order to create that process. So we can go backwards in terms of using it to undertake investigations and things like that, or we can go forwards if we're trying to explore a work system as it is, to figure out what outcomes it's actually leading to. But what actually constitutes a work system? Next slide, please. So let's take an example here. We have a patient who is in an accident. They are, somebody calls an ambulance. They are, paramedics arrive, they provide initial treatment, and they put the patient in the ambulance and they take them to an emergency department. in the emergency department. They are assessed and stabilised by a trauma team. They are then transferred to the operating theatre where they undergo surgery to try and repair some of the injuries that they've sustained. And they are then transferred to a critical care unit. So, is this a work system? Well, the thing about systems is you can go as big or small as you want when you're trying to define a system. So at the big end, the entire health service is a system. Good luck trying to model that using SEEPs. That way madness lies. But it is a single system and all of the components will interact to a greater or lesser extent. But it's too big to be useful to us. So when we're looking at what constitutes a work system, we really need to look at what is going to be a useful size of that system, and when do you need to split things up to actually be more than one work system that you might want to actually analyse separately. So we could argue that this is a single work system, ambulance through to intensive care. You've got a single common factor. You've got the patient on their journey. It's all healthcare. It's all NHS. So there are definitely some common factors and common issues to this. But is treating it as a single work system actually the most useful approach? Or should we be looking at it slightly differently? Well, what would happen if you were to split it up? If you were to say, well, let's say there's two work systems here. Let's say there is the ambulance component, and then there is the in-hospital component. Why would it make sense to split the system up into those two aspects? Well, you could argue that when you look at the different parts of the PET scan, what you would find is that there's not really actually that much in common. I mean, the ambulance uses different people with different training, different skills, different qualifications. It's a different physical environment. It's pre-hospital, it's an ambulance as opposed to being in the building. They probably have different policies and procedures and guidelines and protocols that they are following. They certainly have different equipment. And they also have different organizational priorities and different cultural priorities as well. You know, with the ambulance, the priorities are ambulance response times. That's one of their big drivers. Whereas for us, it's the time the patients spend in ED and getting them through that process is a big driver. And if you want to see the conflict between those two priorities, just go down to ED on an average day and see the ambulance crews queuing outside the hospital trying to offload their patients and the conflict between those two priorities. So what actually do these two bits of the same process have in common? If we're looking at them, you know, do they have common factors? Are there things that are the same across both? Or actually, we're going to make a decision that the things that are common are so small and limited that there's not really much point in keeping them all together as a single system in terms of analysing them. And actually, maybe what we need to do is analyse these as two separate systems, but then also look very carefully at how those two systems connect. So how do we hand the patient between them? Because, you know, as you all know, this is often where things fall down. It's the handover and communication between different teams or different work systems is where things fall over. So we could treat them as different systems, but also make sure we're looking at the period where the patient and the information moves from one to the other to make sure nothing falls down there. Now, so that gives us two systems, but maybe there's more than that. Maybe we could say there was three. I think things have changed a bit now, but if I think back to the beginning of my career, the gap between theatres and intensive care was probably a lot smaller than it is now in terms of what happens. You know, intensive care medicine has become its own specialty over the years now, as opposed to just being something that anaesthetists do as part of their job, which is kind of how it used to be. And the equipment's got more specialist as well. The training's got more specialist. And over time, there's probably less and less of an overlap between what you would expect an anaesthetist and anaesthetic team to be doing and what you would expect an intensivist and an intensive care team to be doing in terms of the people, environment, tools, and everything else. So maybe back in the past, we could have treated those two things as a single separate work system and maybe treated ED slightly differently. I'm not sure that's the case now, though. And I think it would probably depend on where you work. And it's something to think about when you're looking at systems like this is, are they as common as you think, or have they become a lot more diverse and a lot more separate than maybe they used to be, or you think you are? We're back to that work as imagined, work as done concept that Fran was talking about earlier. You know, how much do they really have in common? You could go down the extreme route and say that all four of these things are separate, and therefore we need 4 different SEEPs work systems in order to analyse them. Problem with that, though, is A, it's a lot of work, and B, you're only then really going to focus on the things that are obvious in each small bit, and you're going to miss all of the focus on the bits that connect those different aspects of the system, or the common problems that exist across all of them might not be so obvious. So, for example, you know, IT systems might not seem like a huge factor if you're looking at each of these 4 things separately as a separate work system. But once you start looking at it more broadly, you start trying to think, hang on a minute, IT affects so many other things in these work systems that actually it's a huge, broad underlying influence across the whole system. And actually, maybe it needs a lot more attention and scrutiny than it might warrant if we were only looking at each bit in isolation. And the other problem with this is that if you're looking at each bit separately, you only really pick up on the issues that are what we would call tightly coupled issues and tightly coupled components of a system. And tightly coupled components in a system are when a change in one thing causes a fairly immediate and obvious change in another bit of the system. So if something happens, you see the result very quickly, because we're only looking at a small section here, as opposed to more loosely coupled system components where a change in one thing might take quite a while to see an impact, because the components are quite separate, either by time or by physical distance. You might not see an issue for a while. So you might not see an issue relating to the ambulance service affecting the patient by the time they get to critical care, if you're looking at the components separately. Whereas if that had been maybe an information failure, maybe the paramedics knew that the patient was allergic to antibiotics, for instance, because they had access to that information. Maybe a relative told them that at the scene, but that information got lost in the communication chain. And then by the time the patient arrived at critical care and they were given antibiotics and had an anaphylactic reaction, it might be, if you're looking at all of these systems separately, it might be quite difficult to realize that loosely coupled 2 components of the system are actually connected. Now, there's no one right answer to this. You can't just say, yes, it should definitely be 1, or it should be 2, 3, 4, whatever. It is subjective, and that you will have to kind of make your own decisions about what the best way of doing this is. and there are advantages and disadvantages to each. So what we're going to do now is a quick poll, I believe, I hope, where we're going to see how many different work systems you think we should be using here. If we're looking at this process with the ambulance, ED, theatres, critical care, if you were going to explore this as a work system, how many different work systems do you think there should be? 1, 2, 3, or 4? I will let you vote now. Okay. Can we pop that up at all? Okay, so we seem to have a winner, which is 4. So people treating these as distinct and separate work systems. As I said, there's advantages and disadvantages to each of these options. If you treat them as one, you are definitely covering lots of areas, but you have a lot of complexity and you might not have a lot of commonality. If you treat them as 4, the danger is that you're missing the exchanges and the connections and the handovers between the different aspects. But there is no right answer to this, and it's going to take a bit of practice using SEEPs for you and developing these work system models to kind of figure out what works best for you. It's also going to depend to an extent on what you're actually investigating and, you know, the nature of the system or the nature of the incident maybe that you're actually looking at here to try and understand what the focus is. If the focus is on communication going through a process like this, that's when you might want to look at it as a single system for sure. Whereas if you're looking at it in terms of clinical management and these different components, then treating them as 4 systems might well be more sensible. So it really depends on the situation and what you're looking at. But it's worth bearing in mind, if you find yourself really struggling trying to develop one giant SEEPs work system looking at a particular process, think about breaking it up. Think about how would we divide this up into separate systems. As long as you can, you can make the rationale for why you would put the division there, and as long as you're looking at how those different bits connect. You can't treat them as separate bubbles that have nothing in common, because that's absolutely not the case. And how do things move from one system to another system, all within the big giant system, of course, that they are also in. Okay, so we'll move on to the next slide, if that's okay. So coming back to the individual SEEPs components, what we can see here is we've got our people, organisation, environment, tools, technology, tasks, as we've looked at before. And hopefully, as you're going through, you're doing your PET scan or any other tool that you're using, you're starting to populate these lists with things that you think are important and relevant, whether they are barriers or facilitators. Because remember, we're looking at a system. We're not looking at how did it go wrong. We're looking at where is the variability? Where are the factors that could make it go better than expected or worse than expected, rather than just how did it happen for that particular patient. So we look at these various factors and components. And now what we want to do is kind of explore how they actually interact. How do these affect each other and influence each other? So next slide, please. So you may have seen this if you've gone through all the PSIRF material. This is an example that's used in the NHS England guidance. This was developed at NHS Blood and Tissue, where they were using it to map out some of the issues relating to incompatible ABO blood transfusions. So you can see here, you've got your SEEPs framework here. You've got people in the middle. You've got environment. You've got tasks, tools, all the other different aspects here. So they've picked up things that are either clear barriers and issues or things that could go either way. And you can see here that they've drawn lots of little arrows. And what they're trying to illustrate here is that how does one of these things affect others? So you can see over in the orange, for instance, the organisational, you've got business case for new technology not progressed. So what impact does that have? Well, that means you've got suboptimal technology in the equipment factor. Well, what does that mean? Well, that means that changes how you have to do your blood checks, because you can't use, the technology you might want to use in order to do that. Maybe that's barcode scanners or something like that. So you've got an organizational factor that impacts an equipment factor that impacts a task factor. So you can see how one thing can spread out across your SEEPs framework and have kind of a ripple effect as it goes out and affects other things as well. We can see again in organizational, we've got staffing, band 4 replaced with a band 2. So that impacts on the people. So we've got higher workload and we've got a band 2 being unfamiliar with the environment. And there you can see we've got kind of a loop going on. So the band 2 is unfamiliar with the environment, so that increases the workload as well. So we get a loop effect there where one impact actually makes another impact even worse. Another one we've got here is delays to conduct. So I'm just going to work backwards here. So bed escalation issues. Bed escalation issues in our orange, when we go down to the task, cause a delay in conducting transfusions. So now we're conducting transfusions on the night shift. What's the problem with that? Well, patients don't want to be woken, sorry. And also there are these physical issues. There are the nighttime lighting conditions as well, making it harder to read wristbands or, you know, read documentation or anything like that. So you can see here again that an organisational issue around bed allocation and patients being transferred has impacts across all sorts of different aspects of the system. So next slide, please. So when we're looking at interaction and we're looking at the different components that we've identified in our SEEPs, rather than just look at one individually and say, is this important, yes or no? What you want to be looking at is, what impact does this have across the broader system? How does this thing, this factor, or how could this thing or this factor affect the other components in the system? Now, it may be in the same category. It may be a people factor that affects other people factors, or an equipment factor that affects other equipment factors, or it may go across between different ones. So as we saw previously, organizational factors were affecting equipment, were affecting tasks, were affecting people. And we may find that an equipment factor, something like IT, for instance, has broader effects across lots of other different aspects of the work system as well. So when we're looking at what we think the most important factors are, we need to be thinking about influence and impact. So which factors have the most influence on other parts of the system? Can you identify the factors that are going to affect the most other factors in your SEEPs framework? You know, which are the ones that have the broadest, widest effect that influence the most other things? What is the direction of that influence? So what that means is, you know, if one gets better, does it make the other ones better? Or if one gets better, will another one get worse in order to compensate for that? You know, so you may have a positive impact on one thing, but it causes unintended consequences in other areas. So, you know, think about just because something is good in terms of, you know, on affecting that factor, how may it not be good in other areas? Is it all good? Is every effect going to be good? Or will there be some negative effects and negative consequences? And vice versa. You know, are things that seem bad and seem like they're going to cause problems, are there actually any upsides to that in some other aspects of the system that we've not maybe explored and looked at? And then what is the impact of that influence? You know, what we're trying to really identify here are, as I've mentioned previously, the high leverage points within this system. The bits that are going to have the most impact across the system if you can adapt or change them. So we might identify, for instance, that if we change one thing, it might take a huge amount of work and effort to do, but actually its broader impact across the system is quite minor. And it's not going to address a lot of the underlying problems. Whereas there might be something else like IT, I keep coming back to IT, I'm sure you can all imagine why, that actually would have a wide-reaching, broad impact across the organisation, and it would solve or address or mitigate lots and lots of smaller issues. So it might not have that one big seismic change, but actually the overall impact across the system will be much more significant. So maybe that's where we need to focus our resources and our energies, is going after those pressure points that will actually have that bigger impact. Or, as we've talked about in my group earlier when we're looking at PSIRF, what should our focus be at this stage of implementation? Should it be on the broad, getting the message out to everybody in the organisation about PSIRF and what it's going to involve and what it's going to do? Or are we better off investing our time and energies targeting those high leverage people, the people who've got the clout, the people who hold the purse strings, the people who will basically say yay or nay for their entire team or department or specialty or whatever it is? You know, where do we invest our time in that education and evangelism? You know, do we go broad and shallow, or do we go narrow and deep? And if so, who? Who do we target? Who will give us the most impact into that system? And then tightly coupled or loosely coupled. So as I said, tightly coupled components in a system are where a change in one leads to an immediate, obvious change in another. So if you suddenly lose 3 staff on your team, chances are the impact will be immediate and obvious. You will start to struggle, things will start falling down. You know, if you're talking about a clinical department and you've lost 3 of your staff, you're really going to struggle to deliver the care that you need to deliver. So that's a tightly coupled connection between staffing levels and the ability to do the tasks and work that you're trying to do. And you know, that means it's an easy problem to see. The difficulty is it means you don't have much time to respond if it happens. So if you get a problem with one component in a tightly coupled system, you've got to react very, very quickly before the impact just spreads out across the whole system and you lose control of all of it. And that's the danger with tightly coupled systems. You see the problems, they're very obvious, but you have very little time to respond when they happen. At the other end, you've got loosely coupled systems. You might not realize that a problem with one aspect of the system has caused you a problem until weeks or months down the line. You know, if you think about booking a patient for a follow-up appointment, for instance, in 12 months' time, well, if there's a problem with that process, you won't realize for 12 months. As far as you know, the patient's going to turn up. You'll only know they won't when they don't. And even then, you won't know why. So very, very loosely coupled. And what that means is that, you know, you've got to have, in a loosely coupled system, you've got to have really good processes in place to make sure you've got assurance that things are working, because you're not actually going to see the consequences until quite a way down the line. So understanding whether your components are tightly coupled or loosely coupled tells you whether you're likely to see the impact yourself very easily and very quickly, but not have much time to do anything about it, versus you're really going to have to stay on top of this, figure out if it's going right or going wrong. But at least if it's going wrong, you've got time to deal with it. So tightly coupled and loosely coupled is important in understanding the nature of that connection. Okay, so what we're going to do now is get back into our breakout rooms, and we're going to continue to explore the PSIRF implementation. And what we're going to talk about in this session is, what do you think the key aspects of the system are in terms of implementing PSIRF? What are going to be? We talked about a bit about barriers and facilitators in the previous session, but how do you think those bits are going to impact on the broader areas of the system? Which factors do you feel are going to have the most influence on what you're trying to do? And so which are the factors that you think you're going to need to focus on if you're going to try and make this come out the way you want it to? And sometimes they are obvious factors, but sometimes, as I said, they're more subtle factors that just have a broad, wide impact rather than necessarily an obvious, profound one at a specific point. So hopefully, and when you get into your groups, what we'll come up with is a list of what you feel are the most important system factors that you will need to prioritize and focus on to get the best bang for your buck in terms of implementation. So this slide is kind of I'm teeing up the next session, I guess, next week, which will be looking at improvement and QI and actually making change and leading on improvement. You know, once we've identified our high leverage factors within the system, we then need to be thinking about, okay, well, which ones of these do we need to prioritize and focus on in improvement? You know, with improving any kind of system, whether we're talking about the improving our serious incident investigation system with PSIRF, or improving a patient pathway or anything else. At the end of the day, we are working with limited resources, limited time, limited people, limited budgets, limited everything. So we have to think about bang for our buck. And this is why identifying those high leverage points in your system is important, because they're the things that are going to have the biggest impact, hopefully, for the smallest amount of resource or effort. But just because we've identified high leverage factors doesn't necessarily mean we're going to be able to change them. So we need to look at, well, which of those factors are actually controllable? You know, we might say, well, staffing is a very high leverage factor. IT is a very high leverage factor. You know, effective communications, the broader organization is a high leverage factor. But which one of those are actually within your gift to do anything about? And are you actually able to address them? They can be as important as you like. If there's absolutely nothing you can do about them, then you're just going to have to work around them. You're going to have to treat them as a fixed point, something that is not going to change in the short or medium term, and something you have no control over. Then you start thinking about, okay, if I don't have direct control over that thing and the things it influences, are there any other points in the system I can use to affect some of those things that it influences? I can't get more staff, but I can see the consequences of not having enough staff are X, Y, and Z. Is there any other point in the system I can use to influence X or Y or Z? Because I can't get more staff. And just because something is controllable and we have the ability to do it, is it realistic to expect us to do it? Or is it going to cost far too much money? Is it going to take huge amounts of time that you just don't have? Is it going to require expertise that isn't available to you? Or would it be culturally unacceptable to try and do it? Is your organization just not at the point where you're going to get the buy-in to be able to do that? So that way, hopefully, you can focus on those factors that are going to have the broadest impact across the system, or at least the broadest positive impact across the system. Another question to ask yourself, though, when you're looking at what you're going to target for change is, how confident are you that the outcomes that you're hoping for will actually materialize? And obviously, this is really important if you need to go out and get support or buy-in or money or, you know, staff or anything else to help you with improvement. You know, it's one thing to say, we hope that if we change this thing, it will have this great ripple effect in the system and loads of other things will improve as well. But how confident are we that that will actually happen? You know, how likely do we think it is that we will get that really good positive effect versus maybe a slightly less good effect, but still net positive, versus no effect, or versus a negative effect? You know, and we have to think about, you know, risks here, don't we? And yes, there is a chance of a positive, and maybe we might say, well, there's a chance of a really good outcome, and there's a chance of it will be okay, but not very good. That's a very different proposition from there's a chance it will have a good effect, but there's also a chance it will have a really bad negative effect. You know, that's a different decision to be made. So thinking about how predictable it is that you will get the outcome you want and what the alternative outcomes might be is going to be really important for the people who are actually going to have to make the decision about whether or not you get what you're asking for to address this problem or not. So hopefully this will be stuff that will be covered in a bit more depth next time when we look at QI and improvement and the when, who, when and hows of that. But that next slide, please. But that is me done for my section. Hopefully it's been interesting and given you a bit of food for thought, and I will now hand back to Dale.
So on this slide here, we just have some useful papers. We'll be circulating this later on today in the follow-up email. If we could have the next slide, please, Claudia. So before we start our Q&A session, I'd just like to say a massive thank you to Fran and Steve. Your sessions were absolutely brilliant and they've given us a lot to think about. But I think most importantly, you've helped provide some of the tools so that we can understand how we can use human factors to support us in implementing PSIRF. So we'll now start our Q&A session. So if you have any questions for the speakers, please, if you can either raise your hand or put your question in the chat box. If you do see any questions in the chat that you'd really like to hear answered, please do give them a thumbs up as they'll be more visible to us. And we've got Vicky, who's going to keep an eye on the chat for us and feedback any questions. And most importantly, keep us on time. So Vicky, before we start, can you just let us know how long we've got for this part of the session?
Yeah, so we've got about 15 minutes, Dale.
That's wonderful. Okay, so whilst people are having to think about questions, Fran, if you don't mind, please, I would love to ask you a quick question. So I'm really interested in how we can use human factors to help us authentically implement PSIRF. So I think one of the standouts from last week's webinar from both Dan and Mark was that we're not creating a SIF 2.0. Mm-hmm. I think from the breakout rooms, people were really highlighted. So my question to you, please, is when we're using SEEPs to support PSIRF, who are the right people to involve? And how do we ensure that that involvement is both meaningful and compassionate?
That's a really good question, Dale. So I think what I would strongly advise people to do is to really think about who the people are that are involved in PSIRF, what they're wanting to implement. And so if we're thinking about the implementation process, that's sort of different to sort of how we're using it from a sort of, looking at a particular incident. One of the things that really came out quite strongly in the two focus groups that I facilitated was leadership and engaging leadership, and how the perspective of leadership in terms of their approach to PSIRF, their support of it, their knowledge of it, but also their ability to demonstrate and create a safe culture within an organisation is hugely important. So because that came out a couple of times in the breakout rooms and we were able to have a little bit of a conversation around that, then I think that's an area of focus that people are really thinking about at the moment. And they recognise that actually they are hugely influential in how PSIRF is implemented. One of the things, again, related to that people talked about was that feeling of being able to speak up and that culture. And without having the ability to give staff that feeling of it's okay to speak and it's okay to really engage with this, then that's really quite key in implementing PSIRF properly and avoiding that SIF version 2. So I'm not saying they're the only people to engage with, but I think that's a really good place to start, but not forgetting all of the other people that are in the system as well.
Definitely, I completely agree, Fran. I think PSIRF, we keep on getting the words just culture, a positive safety culture, and I think it's so important that, as you said, we give all people involved in patient safety and caring for patients that confidence to have that psychological safety to speak openly. So thank you for that. And Steve, if you don't mind, I've also got a question for you, please. So I think that the interactions in a system is so interesting. And I think, we're working in such complex, fast-paced environments. So I think it's sometimes it's a little bit hard to know where to start. So what I would like to ask you, please, is when we're considering these interactions, how do we know which element of a system to focus on so that we can make changes that'll have the greatest, most positive impact? So I think you've already touched on this, but if you've got anything else that you'd like to share, that would be fantastic.
I think a lot of this comes back to that kind of tightly coupled, loosely coupled bit, in the sense of how long will it take for a change in one thing to actually show it's made a difference. And what I really mean by that is, this is about, well, who do you need to target first? Because it's going to take the longest time to see the benefit from that thing. So, if we were talking about this in my group, there's no point in targeting potential people who are going to be using the PSIRF framework to undertake investigations until you know what your organisation's model is going to be in terms of who needs to do investigations. Are you going with a full-time investigation model where you have a couple of people who do have a caseload? Are you going with, people will do 1 or 2 a year and you need a broad number of investigators? Until you've answered that question, there's no point in worrying about that bit. So what bit of the system do you need to focus on at that point? Well, you need to focus on the bit that's going to determine funding, that's going to determine your governance and your structure and your model, and you need to be targeting the people who are responsible for that. It's all about thinking about how you order things. So which bits need to happen before other bits of the system are even capable of moving? Sometimes you need this bit to free up before other bits can free up, and you get that cascade. And if you're trying to fix one thing and there's a bit that needs to happen earlier on that you haven't addressed, you're not going to get anywhere.
Mm-hmm.
So or other things will take a long time to happen. If you might need to start some things now, not because you need to be doing anything with them now, but because they're going to take 6 months before anything meaningful actually happens. So you have to prioritize now. So by the time you get to that stage, those things are already happening. So the other bits of the system that they affect are then flexible and you're able to do things with them.
Thank you for that. Yeah. Oh, sorry. Go on.
No, it's okay.
Yeah, thank you for that. I think it's really interesting in terms of how PSIRF is an evolving process. It's not a static thing that we just implement and that's the end of it. So I think as teams and organisations, we really need to have that flexibility and adapt to the systems and needs. So thank you for that, both of you. If I can come to you, Vicky, please, do you have any questions?
Yeah, just some questions in the chat, but also some really great comments as well, Dale, particularly around some good practice that Juliet mentioned at the beginning when Fran was talking about validation, the procedures, looking at work as done and work as imagined, and having a part of their document control processes, which I thought was really interesting, and another really valuable comments in the chat. So please have a look. Tina talked about tracking the incident journey, and I'll just read out her question. If you're investigating an incident, surely you'd be tracking the incident journey rather than each system in isolation. Swiss cheese effect. So I don't know if Steve or Fran would like to comment about investigating an incident and thinking about the journey as a whole. Or Tina, if you'd like to add to that at all, you're very welcome.
Thank you. Yeah, it was obviously, we went back to when we were voting around number of systems, and what we do know is that when things don't go well, it's usually due to a number of factors that kind of line up, hence the Swiss cheese effect. It's very rarely that some things goes wrong in isolation and it it leads to an incident. So I suppose it's about just thinking about that wider rather than in system silos, I suppose.
You certainly need to track the journey because you need to understand what systems the person was interacting with, as they went through that process.
Yeah.
And as I said, you may treat this as a single work system, and you may feel that yes, actually we look at this as a single thing, because there's enough commonality between the different components and there's enough interactivity between the different components that they are functioning as a cohesive system. Or you may feel that actually there are bits that really don't have anything in common other than that they bump together at the point where the patient moves between one and the other. You know, like I said, you may feel that the pre-hospital component, for instance, the only time and way that interacts with the in-hospital component is when the patient moves from one to the other. Therefore, you would treat them as two separate systems, but you would have to look at that interaction because we all know that's where stuff can get lost very easily. So, but if you're trying to put all those together in a single SEEPS, are you going to end up with a lot of things that you're thinking, well, these things don't actually relate to any of these because they're happening in a completely different organisation? As I said, there's not a right answer or a wrong answer because everything's a system if you go out far enough. But it's about what can I work with? What's going to give me useful information here? Do I need to narrow it down? Do I need to broaden it out? And that does come with practice and experience and you know, kind of figuring it out.
Yeah. No, thank you. That's helpful. Thanks.
Thank you, Tina. We also have a question in the chat from Norman McLeod. I don't know if Norman wants to unmute himself and come on the screen, but I'll just read it out anyway. How do you differentiate between actual causation and an assumption? And that was actually popped on when you were doing your presentation, Steve. So just thinking about those interactions, I think that was at that time in your shot diagram.
I take it that means how do you know there will be an interaction versus are you just assuming that one has an effect on another? I'm guessing.
I'd go with that. Yep.
It can be tricky is the answer to that without actually changing something and seeing what happens. It can be difficult to determine that. But sometimes what you want to do is, this is why going outside of an individual incident is important, though. You know, you've got to look at what happens normally, not just what happened at this time. It's very, very easy in incidents to create causation where it doesn't exist, for sure. You know, they didn't follow the policy and this bad thing happened. Therefore, the bad thing happened because they didn't follow the policy. But does anybody ever follow the policy? If nobody ever follows the policy, it is not an influential component of the system. And it's not actually impacting on anything else in the system. It's neither use nor ornament. Now, maybe it should be. And maybe if you had a better or more accessible or more usable policy, whatever the issues are, then you would start to see its influence spread across the system as a whole. So you need to understand the difference between what happened in a particular incident you're looking at and what happens normally to try and understand which things make the difference. What are the variables that actually make the difference? Rather than just making assumptions that the presence or absence of a particular thing in a pathway that led to a bad outcome must have been contributors to that outcome. They might actually just be part of normal work.
Yeah, no, that's a great answer and a really great question from Norman there as well. So thank you for that, Norman. I've got a question as well, Dale, if you'd permit me to ask my question, if that's all right, and it's to Fran. If I could ask you, please, we know that PSIRF is a big change for staff, both from an operational and a cultural perspective, and many staff in healthcare, it's possibly the first time they've interacted with SEEPs, and we certainly talked a little bit about that in our breakout sessions, and that can be quite unnerving because it also came up in our breakout session about having the confidence to use it and the training behind it. And so what would your advice be, or your suggestions to people who perhaps would be doing that in their first time?
I think that's a good question in the sense that I can quite imagine that a lot of people are thinking, what am I going to do with this? And this was something that we raised in our breakout room as well. And I referenced a conversation that I've had recently with Pascal Carrion, who's one of the people who helped develop SEEPs in the first place. And I asked her that exact same question a couple of weeks ago. You know, what would your advice be to people who are struggling to know where to start? And she gave the really great advice, but also sort of quite simplistic advice of just have a go. Don't be scared by it. Don't assume that you're going to get everything right first off, but don't be scared to just dive in and have a go. And I think for me, SEEPs is a brilliant framework because it can be used on lots of different levels. I use it in lots of training to help people understand some of the system factors in human factors. And actually, even as a first step, if people are using it just to help them understand that in order to think about the system, they need to think about the people, the tools and technology, the tasks, the environments and the organisation, it might well lead them to think of things that they hadn't already considered. It might be that when it comes, for example, to procuring equipment, they would think about all the different environments that it would be used in, which is maybe something they wouldn't have considered before. So, for example, when purchasing bariatric beds, it may be that they think, right, can this bed fit down the corridor? Can it get into the lifts? Are we able to move it where we want it to be? Now, that sounds really simple, but actually, just using SEEPs on that level to identify where it's going to go, who's going to use it, the environments, the tasks, may just well help save some problems, incidents, etc. in the future. So I'd say get your confidence up by starting with that left-hand side, that work process element, and start to become really familiar with those system elements so that it becomes second nature to think about the people, the tasks, the environments and the equipment, but then build up. I would also steer people, and this is also, it's really in relation to a question that Ali asked about other human factors tools that you should be aware of when completing SEEPs. I would say go and have a look at the SEEPs 101 paper, which we've referenced at the end. It's not the answer to everything, but that's where the PET scan came from, which might just help you. If you're somebody who likes sort of a tool, a table, that might just help you to have something to get going and get started. Steve, I'd be really interested in your comments as well as to how people get started. They would be my top tips.
I think practice. Don't wait till you're doing an SI investigation before you start messing about with SEEPs. It is a way of modelling a system, and you can use it to model any system you like. So, you know, any examples you get, you know, if you're doing a little reorg of your department, if you're, you know, helping people develop a document or a guideline or something or a new policy, well, map out the system, use SEEPs, you know, have a play around with it, as you say, and see how it works. It's a lens to look at things through. It really is. And as you practice and develop it, that lens will become more familiar and you get more used to seeing problems through a human factors lens, where we see it in terms of systems and the bits and how those systems interact. In terms of human factors, other human factors skills and tools, I think probably the biggest ones are observation and task analysis, and, you know, actually mapping out tasks. Because then you can understand at each stage of the task, okay, well, what are the different factors that affect this stage? You know, it's a good way of kind of going through and making sure you're not missing any factors out. That way you can at each step, you can ask yourself, you can basically PET scan each step, you know, and come up with a definitive list that way. And observation is super important in order to understand what actually goes on the shop floor and move yourself away from the workers' imagine that Fran was talking about earlier. But observation only works if people genuinely believe you are there to help. If you're not going to tell the boss if they're not doing it right, You've got to spend a little bit of time with them just to make them feel comfortable and make them feel that you are there for the right reasons, to understand their jobs, to understand the challenges and obstacles that the organisation throws in their way, and quite often the incredible creativity, ingenuity and resourcefulness they're displaying in order to figure out how to get their work done despite the organisation's efforts to make it difficult for them.
Thank you.
Once they trust you, you won't be able to shut them up, believe me.
Thanks, Steve. Sorry for interrupting you there. And that answered Ali's question beautifully. So fantastic from both of you. And back to you, Dale.
Yeah, thanks, Vicky, and thank you to Steve and Fran and to all of you who have asked us questions. If we could have the next slide, please. So before we finish, next Friday we'll have our third webinar, which will be quality improvement and the model for improvement. Caroline Maurice Tillett and Jodie Mazur from our patient safety team will be presenting, and they will explore how QI methodology can support the development of safer systems to co-create an environment of learning and improvement. So we really hope that you can join us, and I think the link is in the chat. If we can move on to the next slide, please. So on the 24th, we will have our final webinar, which will be a community of discovery. And we invite you to join us to hear some fantastic speakers share their insights into the future of patient safety. We'll also be rejoined by some of the speakers from previous webinars, and we'll undertake a generative discussion and continue to share learning and insights. If we can have the next slide, please. So thank you again to all of you for joining us at today's webinar. We're just going to share a poll in the chat now. So if you can use one word to describe how you feel about implementing PSIRF after today's session, we'd really appreciate that, and it'll create a word cloud. In the chat, we'll also share links to next week's webinar and a link to a short feedback form that we'd really appreciate if you can complete, as it'll help us shape our future events. Later today, you'll also get an email with today's recording, resources, and the links that we've mentioned, as well as a YouTube link, a link to last week's webinar as well, in case you missed it. So thank you again for joining us. A massive thank you to Fran and Steve and to the our patient safety team for supporting this webinar. We hope you all have a lovely day. Thank you.